Welcome to Healthcare Challenges in the U.S. Affiliated Pacific Islands. My name is Alan Tidwell, and I'm the director of the Center for Australian, New Zealand, and Pacific Studies at Georgetown University. It's a pleasure that you could join us here today for, I think, what will turn out to be a very important and informative seminar. The seminar is part of the Southby Seminar series, made possible by a generous gift from Richard and Janet Southby. The Southbys have been supporters of the center for a number of years, and each year we've been so fortunate to be welcomed to welcome speakers with expertise on public health policy and the healthcare system. And once again, we're doing it again. So thank you so much, both Dr. Southbys. Very kind indeed. And this seminar today is part of our Pacific Healthcare Initiative. The Pacific Healthcare Initiative is a program initiated by the Center for Australian, New Zealand, and Pacific Studies. And it's been a program that's been the brainchild of my affiliate of the center, Dr. Eileen Natuzzi. Some of you may know Dr. Natuzzi through her work in the Solomon Islands or her work here at the center. She has been a force of nature in Washington, D.C., promoting the interests of the Pacific Islands here in Washington, D.C. So once again, welcome to the Healthcare Challenges in the U.S. Affiliated Pacific Islands. Eileen, I'm going to throw to you and ask you to kick off the session and introduce our speakers.
Great. Thank you very much, Alan. And thanks to the folks who are joining us. I want to start by thanking each of you for agreeing to participate in this virtual discussion, and it will be recorded for hopefully for future viewing. But what we want to address is the challenges that you face in delivering healthcare in our territories. And let me kind of outline our territories. U.S. Pacific territories consist of Guam, the Northern Mariana Islands, and American Samoa. The representatives today are from those three territories and work within their health systems. I also want to thank each of you for the hospitality you showed me in my recent visit. It was an amazing learning experience, and I hope I didn't talk your ears off during it, but I learned a tremendous amount. So the purpose of this seminar is to have your voices heard and to have your voices carry over to representatives in Washington, D.C., and people who are interested in health in the Pacific Islands. So what I want to do is kind of jump right in and actually have each of you introduce yourselves, and a brief description of what your healthcare system is, how it's organized. So maybe we'll start with folks from Guam, Lillian and Art, if you want to go ahead.
Yes, thank you. Thank you so much for this opportunity to again continue allowing us to express our concerns, our voices with regards to our overall healthcare system on the island. And from my perspective, in terms of the hospital services that I oversee, with me is Art St. Augustine, who is the governor's special assistant for health.
Yes.
But he was also the former director of Department of Public Health and Social Services. So I'll speak from my perspective as the hospital, and then maybe Art can speak from his experience as a public health director former, and also the overall healthcare system, because he does meet with many of us who are directors of those health agencies. So in terms of our perspective from the hospital, we are the only only public hospital on island, and we are the only ones, again, that serve the maternal child health population. Our bed capacity is about 161 bed capacity here in the acute care area. And then we have an off-site skilled nursing facility that is certified for 40 beds. However, because of our staffing situation, we can only accommodate 20 residents into that facility. So in a nutshell, that's what we have. On the acute side here in Tamuning, we not only provide inpatient and emergency room services, but we do some outpatient services with cardiology, with interventional radiology, and now we have gastroenterology, GI specialty, our one and only specialist here on island, who is a local individual, went off to medical school and has come back about a year ago. And so we're really, really very fortunate that he's come back to serve his island. And so we do have that in terms of acute care and outpatient services. And we also have pulmonology. Dr. Jolene Ogden, another local individual who went off for school and is back to us, providing the specialty in terms of pulmonology services. So in a nutshell, that's what we provide here as a hospital. Art, if you want to share more.
Sure. Thank you, Lily, and good morning good afternoon, good evening to everyone. Buenas to my colleague over there in CNMI. Buenas, Esther. I work for the governor's office as the special assistant for health. And in addition to what Lillian is saying, I do want to share with the audience this morning or in this session that we also have 2 federally qualified community health centers. We also have the Guam Regional Medical City, which has 130 plus acute beds. Now,
That's a private.
yeah, it's a private for-profit organization that runs GRMC. And what they've done, they've been doing some renovations internally. So they may have increased their bed numbers, and they're looking to expand as well. And then we have the U.S. Naval Hospital. So we have those others. And then we have private clinics throughout the island. In terms of what I do down at the governor's office, really is to advance healthcare. And so it takes on many different faces. Lillian didn't share this with you yet, but the New York Institute of Technology has entered into agreement, along with GMH entering into that agreement, for perhaps a med student in the 3rd or 4th year to come out here to Guam in August. And so that's one of the agenda items that we're working with from the governor's office, is building our local workforce. But while we're building our local workforce, looking at opportunities, I'm looking and working with WICHE, the Western Interstate Commission on Higher Education, and working with them with the University of New Mexico, again, looking at their 3rd and 4th year medical students, perhaps to come to Guam. This is building off the Guam Behavioral Health and Wellness Center's efforts. They work with the psychiatry department at University of New Mexico alongside with WICHE. And so we're really just wanting to expand that relationship. So we're looking at how we can build capacity for the future. Well, we do have, of course, a lot of locals in med school, but we're also looking for pathways. And so there are different organizations on Guam that are supporting that interest in medical school. But while we're doing that, I'm also working on the workforce development aspect in terms of how we can bring in our neighboring practitioners, healthcare practitioners, be it from South Korea, be it from Thailand, the Philippines, and we're also now looking at India. So I'm working with the Department of Labor and other agencies, what it all involves, what it takes for us to do that. In terms of coverage, we have about maybe, I think 80% of our community is covered based on the census. So there's still work to be done for the rest of the island to have some form of health coverage. But one thing we do ask, and perhaps partners in CNMI and others who receive Medicaid funding, we've achieved 1 of 2 points of parity. It is now 83-17, which is great. Years ago, we were like at 45-50 required batch. Now we're at 17%, right? But what we lack is the other point of parity is the cap. I know there's conversations, and we're hearing conversations in DC about what's going to happen to Medicaid. Well, that is going on. I think it becomes even more imperative that they lift our cap, because if our cap is reduced further, it only impacts and impairs our ability to provide healthcare access and healthcare that is affordable. And so there are other options that we're looking for. Of course, we're always looking to partner with other agencies and organizations, but the governor really wants us to do what we can to ensure that people have access to coverage. And of course, Lillian runs a very dynamic and highly debatable at times the legislature, unfortunately. Yes. It's a public hospital. She turns no one away, and they continually ask her over and over again, every legislative body, we don't turn anyone away in this hospital. It serves everyone that walks into its doors, including especially those who don't have any health insurance. While there is a very, maybe aggressive is a too harsh of a word, but there is a real commitment on Lillian's part and Public Health and Social Services to get these patients with no coverage determined for eligibility for Medicaid, perhaps our local program, the Medically Indigent Program, MIP, But while all that is happening, there's still more work to be done. So if we collectively, and Dr. Natuzzi, if you can help us be a voice for Guam and all those, I think Esther as well, and anyone else in the area that's receiving Medicaid in our Pacific jurisdiction, it's let's lift the cap. The lifting of the cap also, because in case there is a cut, it also then still allows us to do some long-term health planning. When you don't have, right now we can exhaust the funding on just the current enrolled providers. Under this administration, which is the Leon Guerrero Tenorio administration, we expanded Medicaid and we got St. Luke's, which is based on the Philippines, to become an enrolled provider. Well, we have them, I want to say that was in maybe 2023. But even prior to that, we had a prior authorization for cases that are in the Philippines under the medical city. So we're looking to our neighbors to see how we could use their resources and if we can import healthcare practitioners while we build our local capacity. So different organizations on Guam that are supporting students who are interested in med school. We have a teddy bear program. We have a HOME program, which is a mentoring program for students interested in med school. We have GCC, Guam Community College, that is been funded under and is working on behalf of WICHE out here on Guam. Guam University of Guam has an awesome nursing program. And so, and GCC. So we're looking, and I've been working with labor just recently. Last week, I spoke with the Department of Labor on the H-1, H-2 visa, how that works, what the dynamics are. I'm not an expert on H-1, H-2 visas, so if any of you are, I will definitely invite you to call me up and say, okay, this is how the best way to work. But there are opportunities, but we as a local community need to make some decisions about how to pursue H-1 and H-2 visa. And I know there's others that are going to speak, so I just want to say hafa day and buenas, and I'll put up that. Dr. Annie's going to be like, I can keep on talking, but we will have him pause. So no problem, Tuesday. It's good to see you all. Thank you.
Esther, CNMI has a really different approach towards your healthcare system. And I wonder if you can kind of describe that in a little bit of, what the benefit has been to having the corporation.
Yeah. Thank you, Alan, and thank you, Dr. Natuzzi, for inviting me and inviting all of us here. For the CNMIs, it is a little different. We found the value of having one system, one health system with behavioral health, public health, and hospital under one roof. That has been really helpful. We saw that especially succeed in, during the COVID response. It really allowed, providers to basically go across the hallways and work together with public health and vice versa. So our health system is an integrated health system. We do have, it's a one public hospital. It's approved for 86 beds, but we currently have 76 that is in operation. We do, we are an acute hospital. We focus on, on things that we can provide here. We look at what we have done over the past, and mentioning of Medicaid. The Medicaid dollars has been very, very helpful for us to expand services and bring services locally. In the past, we've been referring as simple as even an X-ray or things like that. It's become so easy to just refer people off island. We've managed to reduce the cost of those and try to provide those services. So the expansion of Medicaid from, as Art mentioned, from 45 to 83% has really made us, basically be able to do our job. It gives us more opportunity to do that. And we have reduced the referrals for off-island care for that. We do have workforce challenges as well. That's been, I think, common all over the place. And, in regards to Medicaid, again, we have a lot of our providers. We have private providers. We do have private providers here. We don't have a private hospital, but we do have primary care providers, and the VA clinic is also a private provider here. We have community health centers under a nonprofit organization. They have opened a community health center on the island of Tinian, as well as in San Antonio and in Cagman villages. So that's been the relationship is a little different. It's not under us, but it is part of our health system, of course. We do have I feel like we need to talk about the story too, especially with the economic challenges here in the CNMI, is that we do help in the economy. We
Yeah,
are
Esther,
sorry.
we're going to get to that. And I have a whole, we're
Oh,
going
okay,
we're going to have a whole
okay.
discussion on that.
Well,
'cause
that's not
that
fair.
is
You didn't cut.
incredibly important.
You're cutting me, and you didn't cut them.
Sorry, no,
It's
on
so
economic. I
I
think
am trying to basically talk about the health system,
Sure.
and it is a lot, and I just wanted to express that, and
Sure.
now you've changed my train of thought, but okay.
Oh, sorry.
Hold on to your train of thought on that economy.
Is it okay if we go to American Samoa, or do you want to say, do you have more you want to add, Esther? Because I have a couple of questions to ask that are going to really kind of pull you into more things that I know you and I have discussed.
Well, again, I want to mention the fact that our health system is dynamic, right? I mean, it is different. It is different than everyone else. We do have basically our hospital. We only have one hospital. We are public health. We try to provide public health initiatives, and I mentioned that because of the Medicaid issue. We are spending money based on treatment only, and not so much on public health. And I just want to express that.
Yep.
Thank you.
I agree. Scott, do you want to start with talking about LBJ? Introduce yourself and a little bit about the acute versus public health side of American Samoa's health.
Yeah, sure. Thank you so much. My name is Scott Anesi. I am the CEO of LBJ Tropical Medical Center. Now kind of moving towards American Samoa Medical Center Authority. But we are the only hospital that's in American Samoa. We are a 150-bed facility. We do inpatient and outpatient services. We also offer dialysis services as part of our CKD services. As mentioned by other panelists, I think the word here is unique, but I feel like every health system is unique. The one thing that I will mention is that our number one, we do not have private insurance or private healthcare service delivery systems. What we do is we are blanketed under a broad-based Medicaid waiver that's population-based, which means that our services are provided at a proportion of the population that falls below a certain income level that is a federal rate, which means that the eligibility is not determined locally, but the eligibility is based on proportions of the population that is calculated based on census data. As such, we do have a flat rate system as well as a fee-for-service system. That is how we get our reimbursements. I also just wanted to mention that most of the differences, not only in the healthcare delivery system, but also just in American Samoa in general, is that we're the only part of the United States that are not United States citizens. So all of my counterparts that are from Guam, CNMI, they are all United States citizens. American Samoans are not. And so we have different agreements with the federal government in terms of eligibility, enrollment, as well as our Medicare and Medicaid funding. Thank you.
Dr. Erica, you are the director of the medical clinic, and I wonder if you could just kind of describe a little bit the Department of Health and clinics, your job within the Department of Health.
Yes. Again, thank you for the opportunity. Good to see you again, Dr. Natusi, and good to meet you, Alan, and the rest of the panelists participating today. My name is Erica Sipili. I've retired physician from LBJ emergency room after 30 plus years, and I've recently come into the public health section of the healthcare system here in American Samoa to continue to serve our people here. So I will share what I have learned already here with public health. The Department of Public Health is spearheaded by the Department of Health, or the DOH. It's mostly focused on prevention and promotion of health here on island, preventing any diseases that may be coming in, inflicting our population, as well as promoting health and education, focusing on disease surveillance control, immunization program, MCH programs, and of course, preparing for any disasters that may be coming along our borders in any time and respond appropriately to it. As far as the community health center part of our Department of Health, as we do partner and work along each other, collaborating, the Department of Health as well as the community health centers. There are 7 federally qualified health centers here on island. The main one is located in Tafuna. It's one of the mostly populated region of the main island, which is Tutuila, excuse me. And then there's 3 other on that same island, which are in the outer districts, the eastern, the western, one locally or centrally next to the hospital, and then that Tafuna Health Center that I had mentioned. The Tafuna Health Center is like the more advanced clinic that we have here out of all the clinics, community health clinics that we have, and it's got services that are provided, of course, primary health care to deal with basic care, people with non-communicable disease, treatments and all that. And then we have in there as well is prenatal, women's health, dental, nutrition service, behavioral health, all incorporated in that one building. And then we have, I did mention dental health. And then we have a small lab and a pharmacy there as well, which is satellite pharmacy between the community health centers and the main hospital, LBJ. Excuse me. So this facility that we're having right now is a bit old, and we're in the process of demolishing it and rebuild a better facility for us. So that is in the pipeline with the help of ARPA. So hopefully we'll have that erected in a couple of years' time so we can continue to improve the service here on island as far as providing better healthcare, maybe better equipment coming in. I'll probably get into equipment later on, but we do need all of that for better service here in our island. Thank you.
Thank you, Erica. Esther and Lillian, you both mentioned Medicaid. And Medicaid in the territories is very different from Medicaid in the states. And so that I think some of the people that may be listening to this may not understand the difference. And so I wonder, Esther, could you describe the difference between Medicaid for the territories versus Medicaid for the states?
Sure. So the first thing is that we are capped, unlike the states. I know that there's discussion in the US about capping the rest of the states as well, but for now, the territories are capped. We have what we call the 1108 funding. That's where that funding is paid for the territories. Then we do have we do have funding for children, which is a different bucket as well, and there's different FMAP on that. And then there's the bucket for the freely associated states, and that one is not capped. I want to emphasize that, but because I think, as U.S. citizens, I don't think that was very fair to cap the 11 funding that goes to U.S. citizens. And, nothing against our brothers and sisters in the freely associated states, but you see that unfairness right there, or the disparity there. The FMAP is higher. They've chosen that by statute, and it really puts a more permanent, I think, on the 83% for the FMAP, except for Puerto Rico. I think they're the only ones who are not has that will change on their current percentage for FMAP. There's also a lot of statutory issues that is offered for hospitals that are serving, let's say, for example, safety net hospitals, right? Where Lillian runs a safety net hospital, I run, and so does Scott, right? Safety net hospital. So we take everyone. We don't deny anybody that comes to our hospital. But even within the territories, there is also disparity. And I say that simply because, for example, because I've heard this over 11 years ago, that, what we call how we're paid, we're reimbursed, and who is eligible for the American Samoa. I hear that, and I hear that that is still ongoing on what they call presumptive eligibility, and that is for every patient that goes in. And Scott can correct me, of course, on this, but it is my understanding that their current state plan allows them to allow patients who come to their hospital to be automatically covered or presumed eligible for Medicaid. So I from my understanding, and maybe I'm wrong, but we have a large uncompensated care in Guam and also in the CNMI, because we don't have that. So we are told that we cannot ask for that. And the reason why we're told that is because they feel that that is not allowable anywhere else. And that's not true. We hear that from Medicaid, but that's not necessarily true, because what we know is that actually states are allowed to have presumptive eligibility for, especially when they chose not to expand, because some states could do that through an 1115 waiver, for example. So there's a possibility to help hospitals, safety net hospitals all over, but when it comes to the territories, there's a lot of restrictions. We talked about the statutory of disproportionate share hospitals. I mean, if we are to calculate the disproportionate share in our hospital, and we've done this already to see how it looks, we're talking about after providing the cost report, reconciling on a cost report, and basically determining what is the settlement or what is the amount that is going to be paid on a monthly basis. We are using certified public expenditure, which means that we don't get the 17% in our hospital. We use our current cost as the match. I know that hospitals don't do that. I'm guessing that Guam doesn't do that because they have funding to match. We've chosen to go with certified public expenditure because the government doesn't have the money. And is it, if CHC, the hospital itself, is able to bill on charges as advertised and get 100%, we'd be better off. But we couldn't do that because the local economy, and that's why I mentioned about the economy, the local economy cannot support the match, even if it's as low as 17%. We're talking about 40 to $60 million a year of expenditure. So you're expecting about 20 million of that. I mean, 20% of that, that's very hard for the economy to pay, the local economy to handle. So anyway, going back to the calculation, that the disproportionate share, what they call DISH hospitals, statutorily does not actually excludes the territories. It just basically excludes us. It excludes us in being a sole community hospital. It excludes us in any other means of getting reimbursed besides, reliance on basically are getting reimbursed on the uncompensated part. So we calculated about over $3 million that could come back to us if we are able to become a disproportionate share hospital. $3 million it could buy a lot of supplies, could recruit, and basically provide, adequate and basically take care of the shortfall of running a hospital. But anyway, it doesn't exist now. So that's currently while the territories are, we are, and I want to express this. I'm sorry, because I'm a little bit of, it kind of reminds of why we're here voicing this out, because I feel like it needs to be heard. One of the things too is that, when we're given the money, a capped amount, we're focusing on what we can pay. That's what the Medicaid office does. And when we are entering, when the Medicaid office enters the cost of care, it enters what it can pay. On the CMS 64 document, and, Art can correct me if I'm wrong on this, but what they record is what they're going to pay. So they'll never record what is something they couldn't pay. Right. And so despite the fact that the territories need more money to take care of things, to take care of this population, if it doesn't have the money because it's capped, they will never record it. So that's what had happened to the CNMI. What had happened to the CNMI was that when the time came to determine how much funding should be given to the CNMI, it looked at the records of Medicaid. They looked at the records of Medicaid and what was actually supposed to be paid. It didn't look at what's supposed to be paid that should, that are not allowable at this point. They're looking at it as, well, this is what we project based on the current expenditure. They didn't think about the things that we need. So even if we want to expand the hospital, we want to expand services, those things are not included. And so this is where we come and suffer, because now we're trying to determine what's going to be provided. And we're, as I read in the news yesterday, even with Guam, determining what services to provide. And it's hard because, So anyway, that's the other thing too that frustrates me is when they're reporting, when that number came, that $60 million, it was very wrong. It was not enough. It was determined based on what's showing on the report. They projected, they didn't ask me what they could project. Nobody asked me. And I'm the health official of the CNMI. So,
Esther, if I could just interrupt for a moment, let's hear from some of the other panelists. I'm sure that they have their own perspectives that they might like to offer. So perhaps Lillian, you might like to come in.
Sure. I don't have the detailed description and detailed understanding of the Medicaid because I leave that to our CFO and also with public health. But in terms of the reimbursement, Medicaid mirrors Medicare's reimbursement, which is capped per the TEFRA payment structure. And we only get reimbursed by Medicare at $1,600 per diem per day. Rate. So even if a Medicare patient comes to the hospital into the ICU and the daily bill for that Medicare beneficiary is $10,000, we will only be reimbursed $1,600, and Medicaid mirrors that same rate. And so that's our big challenge is the reimbursement, not just from the CMS, Medicare, but even our third-party commercial payers here in Guam. They have these tactics of delaying or even denying reimbursement, which is happening across the U.S. And so that really ultimately impacts our financial footing for the hospital. And as Esther mentioned, it impacts our supplies, it impacts our recruitment and retention of health professionals. And so, yes, with Medicaid and Medicare, and even the third-party commercial, it does affect our financial footing. And maybe Art can speak a little bit more about the Medicaid program here in Guam.
Sure. I just want to add on to CEO Munoz's comment with regards to Medicaid. She covered it very well. Thank you so much, CEO. Yes, on that report where you only write basically your cap, I think there's room for conversation to be had where you can ask, because we have a cap, for those that have a cap, how much more is expended or needs to be paid that has not been paid. That would at least give a real indication, a true indication of the realities of the different territories that are capped. And so we may get 40, 137 million, but you really need more than that. And formal documentation of an unmet need that would then speak to Congress, and perhaps with your network, perhaps you can be advocates for the territories. Healthcare is critical, and Medicaid definitely is a big pay for Guam. I would say maybe 1/3 of our population is probably under Medicaid. And so that's a significant number of individuals accessing the Medicaid services on Guam. And so I really think, Esther, you covered it quite well. I mean, she covered the math, she covered the reporting. We are looking at waivers and seeing how we can expand services. New York had a demonstration program, and of course, it's up to us to apply as well. But the thing on that is that they actually were granted funding for education for their medical students. And so we're looking at that and better understanding how that is. But if this forum is an opportunity to assist with technical assistance, that would be helpful, I think, to the territories. Hey, this is what's happening in another part of the U.S. or maybe even a territory could be having best practice, and that we could learn from each other and share that wealth of information.
What about American Samoa? I mean, obviously everybody is on Medicaid. So any, issues, how dependent, you've heard Esther, Lillian, and Art talk about Medicaid. What are your issues with it?
I think just before my colleague, Dr. Erica, speaks on the clinics and their funding source, I think, for us, one of the major issues is not really the cap, but it's also we have to go back and look at how the agreements were made, right? And one of the agreements is based on a local match, meaning we'd have to generate a local portion to match federal dollars at a split. Now, for a territory that is highly dependent on federal funds, we can't use federal funds to match other federal funds. So basically what we're doing is we're trying to evaluate this reimbursement system based on encounters and figure out what wiggle room we have to operate within that space so that we're maximizing the cap that we already have. Now, moving forward though, we're strategically evaluating services that would benefit from the fee-for-service reimbursement system. And doing both inpatient and outpatient, some services are better suited for just the encounter-based system that we already have because, they are reimbursed for a service that's delivered at cost, but the benefit to the reimbursement is higher than the cost. But then we also get other services, like anesthesia and some of these other services where now you're looking at the cost for the Medicaid reimbursement being significantly lower than the cost for the services provided. And so now that's what we're strategically looking at. Instead of looking at the expansion for the expanding the cap based on local match, but also based on the population percentage, now we're looking at the actual reimbursements and figuring out the cost per visit, but also for all the services that we're offering and see how we can operate within the fee-for-service space so that we can increase the reimbursements that we're getting. All the other issues that were mentioned by my colleagues in the North are all some things that I think we face universally, where at the end of the day, looking at cost reports and the amount of revenue versus the cost, and then looking at the cap that we're given is significantly smaller than what it would take to operate. And as mentioned previously, just looking at your expenditure reports versus the revenue based solely on Medicaid and Medicare, that proportion is such a small proportion of what you're actually generating in order to run the hospital. So that's something to be looking at. But for us, as we have this sort of blanket coverage through the territory, it's easier for us to kind of pick our spots to where what would make sense. Because let's say we continue with the Medicaid, Medicare program, we pay the premiums, but now we're also enjoying paying for pharmaceuticals and other things at this cost just because they're subsidized. And now if we move into the realm to where we're now getting insurance and we're now getting other claims for fee-for-service, now some of those programs may go away, and we're getting them at face value and at cost. So I mean, the cost to benefit ratio is something that we're evaluating every day, but we're making sure that we're moving in spots or in services that would give us the highest amount of revenue, but also allow us to offer the services and trickle in some of those reimbursements into the other areas to kind of cover up the shortfall.
Yes, Scott. Dr. Erica?
Yes, thank you for the I hear what all the other panelists have shared as far as the financial constraints and limitations are to the territories. And it all comes down to the funding and the money. When we have all these other healthcare initiatives and programs that we want to continue or improve on, even including the infrastructure, workforce capability. But I wish to share that the Congress as well as the policymakers really need to hear from the territories their concerns about finance, because like it's already mentioned that Medicaid is capped, and it would be nice to see it uncapped and be able to maybe get it a little higher, even 100%, or have it equal with the rest of the US states. Unfortunately, it's not the situation with the territories. We do have, LBJ used to have an off-island care program that was provided funding by the government. Unfortunately, we have suspended that because of no funds. So we're pretty much sending patients out if we can, depending on how sick they are. With a Medicaid program, they're sent to New Zealand, which is the closest and probably the cheaper place to send patients to compare to Hawaii and the US. Excuse me, but even sending patients off island, if we could, from the providers, is a challenge because of not only transportation issues, but places for the patients to stay at when they're there with families. Still not enough funding for all that processing of patients being sent off island. And we've had, unfortunately, some challenges with the providers in Hawaii and even some of the places in the US stateside where we could not send patients to them at this point due to some previous bills and things like that the government is unable to pay. So government is trying to distribute its portions of the pie to all the different needs here on island, and it's still not enough. So we are really advertising for help from the federal government as far as money is concerned to help improve and be able to do what we want to do here on island for our healthcare system. Thank you.
Thank you, Erica. You mentioned off-island care, and I wonder if Guam and Northern Marianas you could just mention, where do you refer your patients, and any estimate on what you're spending to send patients off island for care.
If I may, Eileen, and I want to go back to what CEO Esther mentioned with regards to presumptive eligibility for the Medicaid. And I throw this on the table because, we were talking with Director Ariola Public Health that if possible, if the citizens from the islands, like Chuuk and Ponape and the Marshall Islands, if they can be at least be given some kind of a presumptive eligibility or even authorization so that when they come to Guam and all of a sudden they need to be admitted into the hospital, they already have some kind of a coverage with Medicaid, rather than for us trying to get them onto the Medicaid program so that Jimmy be reimbursed. Is that something that can be done and looked into and done so that we can help these COPA citizens now that they're eligible for Medicaid? They can get that authorization or eligibility so that when they come to Guam, they have it already in the system. So I just kind of want to put that on the table. So in terms of the referrals for off island, most of the referrals, it's either Manila, Honolulu, or San Diego or LA for children. Those are where we primarily refer them to. Recently, there have been a few that are referred to like Taiwan, or even to Japan. Not a whole lot. It just kind of depends on their insurance coverage. For those patients who are self-paid, they were trying to get them onto a Medicaid coverage. And in terms of the cost, it kind of depends on their condition. Like, for people with heart condition and they need to have an open bypass in Honolulu or in California, it just depends on the conditions of the individuals. Sometimes these patients are so critically ill that they're brought or air transported by an air ambulance. And that gets covered by the Medicaid or the private insurance. It just kind of, again, depends. Sometimes they're on a stretcher, and that can cost more because the commercial airlines that transports a stretcher, the only airline is United, and that gets pretty costly for just the stretcher alone. Not accommodating the nurse and the physician escort that need to go with these stretcher patients. So
Yep.
the cost it varies.
And Esther, how about Northern Marianas and over off island referrals?
Yeah, so off-island referrals are costly for us as well, especially again going back to the capped amount. It's about, I believe, about a third or more than a third of our funding goes off-island. And, I'm glad that Lillian mentioned about the air ambulance. That's about, let's say, 150 to $200,000 to send someone, to Hawaii or to Los Angeles. And those are the hospitals that we use there. We send to Guam, of course, but Guam has their own shortage as well. So we often send patients to Hawaii or California. We have kind of limited sending patients to Hawaii simply because in the past we couldn't pay, and we had a $6 million, for example, $6 million cap at the time. Prior to the change in the cap, that $6 million was obviously couldn't pay the providers in Hawaii. And, at this point right now, that's another reason why we stick with the certified public expenditures, because when the government doesn't have the money, they have to pay the off-island providers because we tend to be forgiving, right? So we don't get reimbursed, but the providers off island get paid sometimes first before we do. And the other thing too is that the way the Medicaid works, when we're sending patients to California, Medi-Cal rate is much lower, and so they like to have our medical rate, Medicare rate, and they don't necessarily sign an agreement with Medicaid. They would rather do a letter of authorization, because to them they would rather use CNMI, of course, CNMI Medicaid. They love our Medicaid compared to Medi-Cal. And that's how interesting it is, right? And so they don't care about signing agreements, because that would mean that they would follow the rate that Medi-Cal pays in California. So that's why it's so expensive. So it's terrible. It doesn't make sense. Yeah.
And how about American Samoa? You refer, I know that LBJ refers patients off island. Where are you generally referring? And do you have like a rough estimate of how much money you are, spending on referring people off island?
Yeah, we mainly, as mentioned by Dr. Erica, we mainly do referrals to Hawaii and New Zealand. However, there are instances where we send them to other states. It all depends on the accepting physician on the other side that's taking the referral, but also some residents have other types of insurance that they can use in the United States. And so we have that type of fee-based system. We do have fluctuating costs depending on where they go, but typically we put aside a few million for that. I mean, and we have our own Medicaid, office for that. So some years, it goes up based on the severity of condition and the referrals, and some years it's a lot lower. But I just wanted to mention that one of the issues that we're having here is now the dilemma is really, are you going to build up your local infrastructure enough to be able to offer these services and provide it for the people? But then again, if let's say for certain conditions, we're referring maybe 3 to 4 people for that condition off island, the logistics and the cost that it's going to take to get that service in the hospital and then CMS certified could be way more than what we're actually paying per year over a longitudinal period to get the service that they require, just without the cost. So I think most of the islands are kind of at this dilemma phase where, what are the services that you'd like to push for in increasing in your local capacity, just based on your usage, but also what services are you willing to kind of forego and use a referral based system just because it's not as sustainable as moving forward. I mean, the logistics that go into getting CMS certification for certain services, and then also the recruitment, the sustainability of staff, medical equipment, supplies, etc., sometimes does not equate to it becoming a local service. And so that's kind of, I just wanted to mention that because I know we kind of get used to this fact, well, we don't have the services, we should send them off island for the services, or we don't have the services, so we should really move the hospital to getting this service. But then if we look at the data and the amount of people that would require or need this service, does not justify it becoming a goal moving forward. I mean, that's kind of like, it's not an easy conversation to have, but I wanted to bring that up, especially when it comes to off-island referral, because as mentioned, it could go up to millions. Let's say our cap for 1 year is 4 million. With air ambulances and emergencies, we could easily exceed that. But then where do we fall from there? Then either the government subsidy is going to come in, or maybe there's going to be some type of private and government entity that comes together to pay. But I feel like we also need to have that conversation of evaluating the types of referrals, the types of services that we're referring for, as well as some of the specialty care that maybe would be better suited for that, and just look at the type of management or care that you want to offer in-house in the facility. We use New Zealand because, as mentioned before, it's closer to us, but also the dollar for dollar rates that we get in New Zealand are a lot more beneficial to the US dollar, if you will. And we have referral programs that are already set up within our providers that are there. So that's a system that we can. But we also do our opening up our referral programs outside of Hawaii. I know Hawaii is the big one for everyone, but one of the things is just evaluating what the type of services are eligible for off-island referral, and then what are the services that we're striving to kind of make sure that we shore up on island, because I do feel that the need for off-island referral is something that's going to be continuing no matter where the jurisdiction.
Sure. I'm going to shift gears a little bit here because I think it's sort of this is a contemporary topic. Current geopolitical concerns have kind of really have the potential to impact healthcare delivery, in particular in Guam and the Mariana Islands. The terms second island chain and the tip of the spear have been tossed around, and they're very much defense statements. Recently, Admiral Paparo, commander of the U.S. Indo-Pacific Command, testified in front of Congress that said basically military conflict is probably going to come. In a separate testimony, retired Major General Paul Friedrichs actually mentioned that he felt that civilians and military should be working on strengthening trauma systems and critical care systems within your healthcare systems and throughout basically the Northern Pacific. Although I also believe that American Samoa should be involved in that because you are no stranger to tsunamis and earthquakes and cyclones and whatnot. I wonder if each of you can kind of mention your concerns on this, how you're approaching this. Do you feel that your health systems are prepared for this? And let's start with American Samoa and then we'll go backwards.
With public health, I think that's one of the reason behind erupting this new facility. It's a two-story facility because the current facility right now, when it rains a lot, it floods all over around the building, and it's difficult for patients to come around to park and all that. So to erupt that second floor would probably be better for patient and clinics, and then use the bottom floor for other projects or other offices or whatnot that have nothing to do with patient care. Yeah, we do get attacked by cyclones on occasions. We had one tsunami in the past couple of years, which was a disaster for the island. Never experienced that. Fortunately, it wasn't as bad. I think it only killed 30 plus people out of our population of 55 at the moment. But yeah, heavy rains and hurricanes, cyclones attacks us every now and then. And then, of course, pandemic, just like the COVID that hit us and other outbreaks of diseases. So it can get worse. We never know, but we need to get prepared as far as facility-wise is concerned. The capacity of our current hospital, as well as our health, as well as our public health community clinics, is sure not enough at this point to handle any major disasters that would come in on island. So that is something that we definitely need to foresee and proactively work at for any worse events that could happen in the future.
Yep.
Thank you, Dr. Erica. Just to add on to that, I mean, being the only hospital on the island chain and also being in a tsunami zone, but also not to mention there's only one road on the island. So we're talking about infrastructure issues that could directly affect our ability to handle any surge. But I think the most important fact is that we have contingencies and resiliency plans that are put in place for specific surges. However, what I'll say is that not knowing what the surge could be, I feel like it's more important because it's a real finite time that we can be able to handle that surge, and I feel like that's something that is not often evaluated because we build these structures and we have these surge plans, but the time is ticking, and how long are we able to operate at a surge level? And I feel like that's the biggest issue.
Yep.
Because I'm confident in, say, an event that occurs, and then you have, maybe another following period but then we also have emergency dispatchment. There's a lot of things that occur after that. But I feel like one of the biggest issues that we're focused on here in terms of our emergency management is extending that time frame of being self-reliant on the surge and making sure that the capacity that we have to handle the surge could be drawn out a lot longer than we thought. Because I feel like that if there is any conflict or if there is anything that's discussed when we're talking about medical emergencies in our region, we have to make sure that people realize how massive the Pacific Islands and the Pacific Ocean actually is, and how much ground there is to cover, or how much ocean there is to cover. But if help is to come from Hawaii, if help is to come from all of these places, we're talking about still hours out, and priorities may not be for a remote island that is got a small portion of the population. And so I feel like our resilience and our surge plans have to include some type of plan for increasing that sustainability so that we can be able to handle these these emergencies and these surges a little bit longer than the usual 48 to 72 hour acute surge plans that are usually in place.
Yeah. Esther, how about Mariana's? You might be muted.
Sorry about that. Yes,
No.
I think it's you know, it may be a little bit too late, but I think it's very important that there's a lot of training. I think there's a opportunity for training, training our resources here, our personnel, also resource sharing. There's right now we currently use DoD to transport patients to Guam, for example, but that's based on their availability. And so there's an opportunity to help us with our infrastructure, to manage large scale casualties. I mean, that is definitely something that we could be we would love to see how that can basically go through our system. Our system is I think it's well known in our jurisdictions that we don't have that strong infrastructure. We're talking about there's actually a study conducted by DOI through the USACE, Army Corps of Engineers, that shows that our facilities are aging, and it'll be good for the military to help with that. And again, going back to training and resource, sharing, logistics.
Great. And Lillian and Art, I mean, Guam is kind of heavily military. I think 35%, 40% of the island is U.S. military. How do you feel? Even having the military hospital on the island as well as the private hospital, how do you feel you're prepared to deal with a surge in mass casualties if there is something?
Honestly, I don't feel that we are prepared. Our facility here is, as Esther pointed out, it is aged. According to the U.S. Army Corps of Engineers, when they did their assessment in 2019, we're not recognized or designated as a trauma center at any level. But because we are the only public hospital, we take any trauma that comes through, and so we do have limited capacity in our emergency room and in our trauma rooms in the emergency room, and so there is a lot of bus work going around within the military to prepare, and we've been having quite a bit of visits. In fact, we're being visited Thursday by the U.S. Navy Secretary coming here to tour our facility, and there have been several others who have come to take a look at our facility. But again, I'm just concerned that we just don't have the capacity. Yes, we can have the training, but the structure itself, we don't have it available. And the military is building up the military defense agency. They're building up their capacity too to defend, if there's any potential attack, because strategically, Guam is looked at as as a very strategic value to the military, to the U.S. And so we are a target that can happen anytime. But our facility, our resources, our workforce, we don't really have that capacity to respond to if there's any trauma or any kind of a mass casualty. We practice and we do drills to prepare for it, but we recognize our limitations and our challenges. So Art, do you want to?
Sure, absolutely. To add on to Lillian's comment, I'll make this really quick and brief, but at the end of the day, really, we're looking into DoD for partnership. We're looking for DoD for partnership. As many of you may know, or some of you may have heard, the governor has been a true advocate to build a new hospital. Well, that's going to take years. The idea of military partnership could make that happen sooner than later. Recognizing there's a shared vision, there's a shared need, there's a shared plan in terms of what could happen should there be mass casualty. Now, another question that will come up is if we do expedite the construction of a new hospital, what will happen to the current hospital? Perhaps that's an opportunity for DoD to consider this hospital, this location, to retrofit it, to refurbish it, to strengthen it. It may not be as big, perhaps it may need to be resized, but what is operational, functional? There are existing capacities within the structure. It is an aging structure, and there is a high cost related to refurbishing and renovating the hospital. But if we're going to have a new hospital and we are looking at perhaps an alternate site for a trauma center, if not added on to the new hospital. And so really looking to DOD, I know the governor has had multiple meetings with different defense representatives and has expressed this request on multiple occasions. And she's, I believe, even gone public and have expressed that she is looking to the military and to our partners in the military to look at how they can assist us move this effort forward. The original plan for the hospital was not successful given some local situations that were had to be dealt with. But definitely in that right of it, it's very clear that there was a partnership already expressed that in the event there is a situation that the Department of Defense with the Guam government to ensure or to do their best to ensure that we address a mass casualty situation. Some food for thought perhaps that we could be advocates for.
Thank you. You kind of have mentioned your governors in some of the discussion. How do you feel about the representation that you have gotten and in particular in addressing the challenges that you face in delivering care to the population? Lillian, maybe if you want to start.
Sure. Our governor, because she's a nurse, she's got that healthcare background. She's been very, very supportive, been very vocal when she goes off island to DC or even to California, advocating for the island's healthcare system and really trying to get it enhanced and fortified to prepare for whatever future needs or whatever disaster that may come to Guam. So she is representing the island throughout wherever she goes to, even with the military, Department of Defense. Right. And she's got that relationship and the communication and collaboration representing the island very well, very strongly. So right. The Secretary of Defense, Pete Hegseth, was here, and she had a meeting with them. And so she really represents the island very strongly.
Right. Esther, how about you? Do you feel that your concerns and issues are being addressed by representatives?
I think so, but there's obviously a vote would be good. Vote for the delegates. It would be really, really, I think, positive. I know that they've tried to join committees that are, especially the committees that are affecting our jurisdictions and what's important for us. But I think the lack of the vote is something that is obviously not, maybe they're not listening to them as much as they would listen to somebody who has a vote. So, that I think is a challenge. So, but it'll be nice to have, we have a representation in the House. It'll be nice to have equal representation in the Senate. So that would be, that'll be really a plus for us. I think if that's an opportunity, I think that's where we're really equal in representation, at least in the Senate, if we have that possibility. Great. Thank you.
How about American Samoa, Scott or Dr. Erica? Do you feel your representation is good?
I'm not too sure, but like Esther was saying, because we're non-voting, they don't have the voting capacity, so maybe that might be a hinder. The thing with another representative in the Senate that had not been discussed, I don't know if that will make any difference, but I would assume it would, to have supporters from the House as well as the Senate to boost or bring forward what we need here on island to Congress and the policymakers there. But I believe she's doing her best over there to try to represent our needs here in American Samoa in the best she can. I'm sure she.
Thank you, Dr. Erica. I think I just want to add on to that. One of the aspects of representation and advocacy, I feel like, also just falls back on us as the entities to make sure that we are advocating for our needs and priorities and communicating that effectively. I think one of the main things is we have to be able to bridge that communication gap, because our representation to Washington is not only bringing healthcare needs and issues, but also you're talking about needs of the whole population. And so prioritizing those needs and when to advocate and who to advocate with is something I feel that it also falls on our part to make sure that our communication is also being done, but also that we're pushing and we're advocating for specific needs. I think it's difficult for the islands as separate entities or separate territories. It's difficult because of priorities, and our uniqueness also makes different competing priorities sometimes. But I feel like where we would also need to come collectively together is finding that those issues, we all agree on the Medicaid issues. We kind of agree on all of these cross cutting issues that I feel should be communicated as a group, also not only to our specific representatives, but also to the collective, and say that these are at basis these priorities that are seen across territories, and then make sure that the individual ones are also communicated well.
I think maybe one more question before we go ahead and take questions from the viewers. Earlier, Esther, you mentioned economic impacts on delivering healthcare, and each of the territories have really different economics. In Guam, it's very much military as well as tourism. In American Samoa, there's the tuna cannery, Starkist, which employs more than 2,000 people and supplies 40% of the U.S. canned tuna. That's a big chunk. In CNMI, it's tourism, but I know that tourism in our conversations that we've had has been somewhat suppressed. And yet, CNMI has a history of having a garment district where manufacturing was done. How do you see these economic forces holding you back? And is there a role for talking about statehood as a way to drive them? Start with you, Esther.
Okay. I don't want to go to the last question about statehood. I think that's a topic I don't want to touch with the 10-foot pole. However, I do want to talk about, yes, the economic situation here in the CNMI, of course, that affects the social determinants of health. We're seeing more patients coming into our hospitals, can't afford just basic, medication. So we are working with, we try to find resources out there to provide these medications for the indigent. So I think we've been successful in that. But still, we're talking about mental health issues. Those things are increasing, and we're seeing a lot of, again, poverty going on here, and because as a result of the economic situation. I'll tell you a story. I mean, we have a patient that was sent on referral, to Rady's Hospital in California, and this just happened yesterday. And the comment from our staff that works there is that as simple as diapers, the family cannot even afford to have the diapers, with them. And, obviously we facilitate healthcare delivery and making sure that they're brought there, they're picked up there, they're put in a housing, provide them assistance. But, those things are not really covered by the program. But then you think about it, it's like, well, we should, how do we make sure that the baby's healthy if the parents can't even afford the diapers? I mean, that's the challenges that we're seeing. It's beyond just the walls of the hospital and the health system. It's what's happening out there, and it's affecting how our workforce. I mean, it's just devastating to watch. But I'll tell you the reason why I mentioned about the economic impact is that I would like to, to stress the importance of the fact that our workforce contributes to the economy. Right now, if anything, that's what we do, right? At least, we're going to the restaurants, we're patronizing the airlines. I mean, the airlines are making money out of the fact that we're sending patients off island too. So we help. I mean, that's the thing I would like to see, that the health industry gets more highlighted as a contributor to the economy. And, especially with Medicaid, the expression of we need 100% coverage of Medicaid, that's actually not a tall ask, considering the fact that you've given us $6 million in the past. I think it's time that I wish that, policymakers would consider, look at what they have supported for the territories in the past. The history has to be stressed because, they're talking about cutting. And when you haven't given us, you keep moving the goalpost. Every time we're trying to improve our health system, you keep moving that goalpost. And we've never even gone to the 10-yard line, because every time we go to the 10-yard line, somebody comes and pushes us back. So I feel like those policies need to be changed and really think about the history and improve and fix it. And then you can start talking about, are we accountable for our funds? Those things are just, it's just not fair. The way things have been done for the territories has been a shortfall since the beginning, and it's time to correct it. And that's why I'm sorry if I'm a little bit, passionate about this, but this is why it is important to go back to the table and look at really what it costs to deliver healthcare in the territories and say, hey, maybe that $60 million is really not enough. As mentioned, we can't, I'm sorry, I'm doing one more statement. As mentioned, we cannot stop referring patients off island. We will always, there's just no way, a 50,000 population to be able to have the, thoracic surgery here. I mean, it doesn't make sense, right?
Right.
Or the bottom line is we will always have people that need the care. And the question there is, how can we make it available? It's difficult if you are not providing the right policies, that is not cookie cutter, by the way, that really focuses on helping the territories. Anyway, that's my say. Thank you.
Well said. Lillian, how about
Yes,
Guam and the impact of the economy?
yes, well said, CEO Esther, and I do also concur, and I do agree with her statements. And yes, we're seeing it here on our island, the increase in terms of poverty, the increase of mental health issues. At the same time, we continue to have the brain drain. Young people from our island who, go off for schooling or whatever, they leave the island. People have left the island, families have moved off island, and, we're seeing it in the school population, where the school population has decreased and some of the schools may be closing because the decrease in the school population. But yes, I agree that and then the salaries of our workers here, it's low, and so they go off island because they get paid more for the same position and the same job, same duties. So it's a cycle. It really is a cycle. Prices have gone up. I mean, everything's gone up, and so therefore, it just really gets compounded. Our economic situation, the economic impact on our healthcare, it really does have that negative impact. So I don't know, Art, if you want to add more.
Sure. I just want to touch base on Dr. Natuzzi when you mentioned the economy in Guam is driven by the military and tourism. Yes, definitely because of the investment for DoD and our strategic importance and significance out here, there has been a significant increase in military spending on Guam. Recent articles is showing that we have collected a surplus. Well, that is true. On the tourism side, absent the military, we would not be in a good place at all.
Mhm.
If the military was not doing what it was doing, is not investing in the global situation that we are planning and preparing and in anticipation of and for, our tourism is struggling. We have stories of establishments that have closed, have not reopened. We have stories of individuals saying, it does not improve anywhere from the 6 to 9 months, from maybe a month ago, they're looking to close their establishments as well. Establishments closing early because of workforce. There just isn't enough workforce to keep their businesses open. So definitely, our economy is impacted. Thank you. But also, as CEO Munya mentioned, the social determinants of health, and Lillian, we echo all that. And there is an increasing number of homelessness. We are now looking at setting up, and we have set up some, and some soon to open, shelter services, residential programs, a step-down facility, assisted living facility. That's still being defined, but the structure has already been acquired in anticipation of how we could help some of our residents, some of the people who make Guam their home, who live on Guam, to age in place and age with dignity and integrity. So just wanted to add that on as well. Thank you very much.
Yep. Thank you. Scott, how do you see the economy, the local economy in American Samoa impacting your healthcare delivery? And I am going to ask you the loaded question. Has American Samoa, since you are nationals, ever considered statehood?
Yeah, I think, well, I think we'll get to the second question first. One of the major aspects that is that it's being nationals has allowed American Samoa to control immigration. It also has allowed us to own our own land without federal. We don't pay land taxes. If it's in your family's name, you own the home. I mean, that's it. There's certain specific rights that our people are afforded that I feel are strong enough to make sure that that conversation is there. But I will say that I feel like we don't see it until the other tail end is when you move off island. Then you can't hold a federal job because you're not a citizen. There's also certain benefits that are afforded to specific citizens. Now, where the language doesn't say it, then we can get the benefit. But I do feel that there will come a time where the generation that's moving off island for higher pay and better jobs, there will come a time where maybe that conversation will come up. But I do feel that locally, the temperature here is that we're enjoying the agreement based on what the benefits we get. And then I'll move over to the healthcare. My colleagues really said it great. I think CEO Esther mentioned, federal government's having this cookie cutter approach that first, if let's say the healthcare systems in the territories are kind of an afterthought, then whatever's left over or whatever's on the tail end kind of gets redistributed. But also, it's not really specific to the unique needs. Now, I get that because we're such a small portion of the population. But the one thing that I do realize is that there's a severe underestimate for the cost of healthcare in all the territories, because those cost estimates are coming from, let's take diabetes and obesity. You're talking about cost estimates for those portions in the populations that are not taken in high prevalent areas. So let's say we've got, we're top 5 in most of your comorbidities and those like NCD category. But what also is not taken into account, that snowball effect on everything else. When you have, let's say, COVID, when you have other respiratory illnesses, having these comorbidities then complicates that. So now you're talking about extended management, you're talking about extended care in a population that is very, very highly prevalent in all of these areas. So we talk about social determinants of health, but I also feel that it's severely undercutted when the population estimates based on healthcare are generally based on case-by-case basis, but not taken into account when you're dealing with a population with very high prevalence rates. And then you get the snowball effect of now your respiratory panels, now you're using more labs, now you're using more beds, now your stays in the ER are longer. Now, all of these other things are kind of this domino effect that happens within your community, that now the burden of healthcare in your territory per population is severely out of control, but it's underestimated based on the money that you're allocated. So either maybe we can do that through research, or we can do that through, further studies and development. But I do feel that the true burden of healthcare is very, very complicated in the territories, just because we have very, very high rates of comorbidities within our population.
Yeah, that's great. I wonder, Alan, if we have a couple more minutes to take any questions from any of the viewers.
We
Uh,
we've got one question, and we are very tight on time. I can read the question to you if you like.
Sure.
Sure. So the question is, given the number of veterans from these and other Pacific Islands, I'm wondering how many VA health facilities on island fit into the overall healthcare systems. And that's for anyone.
We here in American Samoa, we do have one VA clinic that is servicing the veterans. I'm not exactly sure as of what they are providing in their clinic for their patients, but I do know that some of their patients are able to be sent off to Hawaii for follow-up with, free airfare as being veterans. So I think in that regard, they are a bit more beneficial they have that benefit as far as the healthcare provision is concerned compared to most of the population here on island.
Yes, sir. I think you have a VA, there's a VA clinic on Saipan, is that correct?
Right, we do have VA clinic on Saipan, and believe the community health centers as well as our clinics here do treat patients also as well. They do have that option. And we do, my understanding is that they do travel to Guam and Hawaii at most of the time they pay it on their own and get reimbursed later. So that is something that that is available. We do connect with them whenever there is a veteran that needs to be transported outside the CNMI, for example, emergency. We have to connect with Hawaii, a contact person, and basically have our provider talk to them. And then obviously it depends on how fast the patient needs to get out. There is a Hawaii Lifeline that comes in and basically comes and picks up the patient, but sometimes we would have to arrange that ourselves. So it's there's a system in place to transport patients and send patients off island for veterans.
Great. In Art in Guam?
Sure. So very close to the Naval Hospital is CBOC. And so we have one up there in Agana Heights. And then just in the paper, I want to say this morning, I thought I just read that we're looking to open a second CBOC, which is going to be near the Guam Regional Medical City. About 2 weeks ago also, now it's not a clinic, but telehealth was open at the Inalaha Mirrors office. So vets can go down there and get onto kind of like we're doing a Zoom and talk to a health provider and get some information and some guidance on their health care. Lastly, the governor in her plan for the medical complex, it does include the idea that we would have a VA operating clinic there as well for veterans to be able to receive services there. Now, of course, that's probably a DoD defense final decision to be made, but definitely that's in the plans and conversation we have with our Guam Medical Complex. It's going to be a multi-agency, really center point of services from Guam Behavioral Health and Wellness Center to Public Health and Social Services, Guam Memorial Hospital. The idea is also to have that VA clinic there as an option for services. So that's all I have at this time. Thank you.
Great.
Thank you very much. Unfortunately, we've come to the end of our allotted time. I want to thank the panelists for what a fascinating, in-depth discussion of the challenges that are faced by the Pacific Island U.S. territories. Eileen, I want to thank you so much for your time and for your hard work and your travel throughout the region. I want to wish everyone all the best. And I hope that you'll be able to share a copy of this video. We'll send it to you shortly, but share this copy of this video with friends and colleagues. Once again, thank you so much. Good night.
Thank you very much.
Thank you.
Bye-bye.